Now, the post-stroke seizures, the stroke world talks about seizures differently. The epilepsy world talks about these seizures differently. The stroke world talks about post-stroke seizures as acute post-stroke seizures, which are less than 2 weeks into stroke, and late post-stroke seizures, which are more than 2 weeks into stroke. Whereas, because I come from epilepsy, acute symptomatic seizures, which are due to vascular cause, occur within 24 hours of the vascular insult. So that's an hyperacute seizure. So the epilepsy world is talking about acute symptomatic seizures, which is otherwise known as AS, within 24 hours of the vascular event, and it's not uncommon, about 15% will have this. If you look at late seizures, in the older age, the acute symptomatic seizures can be as high as 50%. So acute symptomatic seizures are more likely in the older age as compared to the younger age. Now, if you look at the incidence country-wise, this is a more recent study by Wang in 2017, and you can see India is represented here, at least in the acute symptomatic category. It's about 3% overall. If you look at the distribution of vascular causes as a cause of epilepsy, it's not less, 32% of epilepsy, particularly in older age, can be due to a vascular cause. And mind you, in older age, occult vascular disease, never presented with a stroke, never had weakness, can have seizures and epilepsy due to a vascular cause. And when you do the imaging, you'll find all these multiple small lesions which are not there in a symptomatic stroke zone, but in a symptomatic epileptogenic zone. So as I said, the stroke world looks at post-stroke seizures differently, as early within 2 weeks and late out of 2 weeks, whereas the epilepsy world looks at it as acute symptomatic seizures and post-stroke epilepsy. Now, this is a large study worth mentioning where they have followed up a community. We don't have any community follow-up studies in our setting. And as you can see here, in this study, within the first 5 years was the highest chance of having seizures in patients who had had stroke to the tune of 11%. So which kind of stroke is going to present with seizures, whether it's acute or whether it's epilepsy? It's definitely going to be more common in hemorrhages, 15%, particularly if it's a lobar hemorrhage, because it's obviously near the cortical surface. It's then going to be commoner in subarachnoid hemorrhage. So basically, post-stroke seizures are going to be a neurosurgical headache. And that's why our neurosurgeons are so cautious about starting anticonvulsants in all these patients. In SAH, it's going to be about 8, so 50% of that of lobar hemorrhage. Next comes cortical infarcts, which is about 6%. Then hemispheric TIAs, which is about 4%. And lacunar infarcts, it's really rare, 1%. And you're never really going to see them in infratentorial hemorrhages and brainstem infarcts, except I'll show you a case. And it's going to be more common in CVT, 40. And by 2 weeks, it's going to reduce to about 7%. And of course, most of these seizures are going to be focal seizures. 40% may, however, be generalized seizures. So this is just going to give you the odds ratio of both acute as well as late seizures. Acute seizures, the odds ratio is almost 2 in ICH. And of course, late seizures more in cortical involvement strokes and severe strokes, to the tune of odds ratio increasing to 5 times more. Are there predictive scores? Are there predictive factors? Could you help your patients out? Could you keep a close track of these patients? Yes, if your patient has a cortical involvement, if your patient has a hemorrhagic infarct, if your patient has prolonged agitated confusional state and has a very severe stroke, please be sensitized to the fact that these people could have seizures in your ICU, in your hospital, or after discharge. And if the stroke is associated with metabolic problems, whether it's hyponatremia or hypocalcemia or whatever, There are certain scores, these are good scores, just like you have Hasbled score for bleeding or ABCD, CD. The epilepsy guys and the stroke guys met together and formed the score which is known as the CAVE score for ICH. So this is predicting late seizures following ICH. C is cortical involvement, 1 point, A is age, less than 65, V is volume, E is early seizure. And you can see the more the number of points there, the higher the chance that your patient is going to have a seizure in a ICH. So this is something which neurosurgeons use routinely. And of course, there's another risk scale for post-stroke epilepsy, which we use as epileptologists. Wherever there is a stroke clinic associated along with the care team, and there are points again for each of these. So please make use of these scores, particularly when you are wary that your patient could have seizures. There are other predictors. If you find periodic lateralized discharges in your EEG, if you find focal transients with its spike or polyspikes, it increases the risk of post-stroke epilepsy, and please use EEG in these high-risk patients to kind of predict. It could predict as much as 17%. Of course, you are going to look at the strokes, but as I said, posterior circulation strokes, you're going to be having rarer seizures, excepting in patients where there is involvement of the mesial limbic cortex. So wherever you have a posterior circulation stroke, which is involving the hippocampus and parahippocampus, again be sensitive to the fact that this patient could present with seizures later on. Initial stroke severity, Scandinavian stroke scale applied to the study. The study is cut off there for some reason, the bottom. And you can see the very severe strokes, there's going to be more risk of seizures, as I said. So what is causing these seizures? Well, there are several hypotheses for acute seizures. There are hypotheses for late seizures. For acute seizures, it's of course going to be the usual increased glutamate, decreased GABA. For late seizures, it's going to be the gliosis, the bleeds, the hemosiderin deposits which are causing it, and a downward cascade of events which could then eventually cause even status in your patients with stroke. So that's just to give you the transit between an ischemic neuron to an epileptic neuron, and the reason why you really need to be neurologists and not just be pigeonholed into stroke neurology and epilepsy neurology. Does having seizures impact stroke or vice versa? Yes, it does. If your patient has had seizures in stroke, the outcomes are going to be worse. You may have a mortality at your hands if it goes undetected, particularly if there is a status in a stroke patient. You can have seizures when you're thrombolizing patients, and this is something which you really need to be glad about, because it's said that if a patient has a seizure during thrombolysis, that means your thrombolysis is effective and there is restoration of blood flow. Of course, you would have to start an anticonvulsant, but it's just showing that your thrombolysis is good. How do you manage your post-stroke seizures? For acute post-stroke seizure, to prevent it, do not use prophylaxis. So there's no recommendation for routine prophylaxis. A blind prophylaxis of stroke patients with anticonvulsants is not advocated. But if your acute stroke patient has had a single seizure, you cannot ignore it, and you would start an anticonvulsant, particularly in patients who are having ICH, SAH, and even ischemic stroke. Chronic AED therapy is not required. So you would give the anticonvulsant for a month or so, and sometimes for 3 months, and then taper it. You'd probably do an EEG just to be sure. The Indian guidelines published in 2019, given by the Ministry of Health, which say in acute stroke, there is no seizure drug to be started routinely, and if there's a single seizure, started. So you are protected by this guideline given by the ministry, so don't blindly start all patients with stroke with anticonvulsant. Post-stroke seizures, there are a number of articles, but previously when we didn't have the newer drugs, there were conventional agents. There is a drawback of these conventional agents because many of them are enzyme inducers. I personally do not recommend using enzyme inducers or conventional agents. The newer drugs like levetiracetam, lamotrigine, gabapentin is particularly useful if you have a patient with severe renal impairment. use these, and there is evidence that retention rates are better with levetiracetam and lamotrigine. There is evidence that conventional AEDs need switching to the newer agents which is available to us. However, there is no randomized large study, and a systematic review and network meta-analysis done on this aspect clearly said that more trials are needed for which drug is best for a post-stroke seizure. So again, I would go back to using the newer drugs in these. Levetiracetam, again, levetiracetam is supposed to be protective for the neurons, so that's another reason. It's supposed to have no pharmacological interaction. Last but not the least, post-stroke status epilepticus is not uncommon. 20% will have it, and late status will be seen in 6% and early status in 13%. Non-convulsive status is again very common. Again, last not the least is the fact that many of our patients who are undergoing revascularization strategies, if you're working in a unit which is doing stenting or endarterectomy, more common after endarterectomy, less common after stenting and mechanical thrombectomy is the fact that during revascularization, due to an acute revascularization injury, hyperperfusion, there could be seizures. I think my time is up, and you have to be alert to this possibility and probably start them on anticonvulsants which can be given for a short term. So what are the 2019 updated guidelines? Apart from what I just told you, there is no clear recommendation of universal prophylaxis of anticonvulsants in stroke patients. Wherever the stroke presents with seizures, there is no contraindication for thrombolysis, and late post-stroke seizures have to be managed accordingly. I don't think I have time to go into subarachnoid hemorrhage. I'll skip that. CVT I've already told you about. There are several challenges managing both stroke and seizures. These challenges have to be overcome by an increased sensitivity to the diagnosis, a pragmatic management in the absence of firm randomized controlled trials. Thank you.